Hello, 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 hello.
The normal is 35 to 45, right? Any number below 35, it's alkali.
Yes.
Okay? Any level above 45, it's acidosis. Okay? Acidosis. Coming to bicarb, it's 22 to 26. Any level below 22 is acidosis. And any level above 26 is alkalosis. We are all okay? Yeah.
Yes, sio kukosea, ila nafikiri kuna zile teme za acidemia.
Yeah.
Acidosis.
Yes,
Nafikiri kwenye pH.
acidemia.
Yeah.
Okay, so these are just the terminology, acidemia, alkalemia. When you're saying in the pH, upper acidosis, okay? So these are the just terminologies.
What's the difference?
Okay, the difference it has been said in the textbook. So yeah, you have to. That's why he corrected me.
So the first is a status.
Status, yeah.
The status of the blood is acidemic,
Yeah.
based on the pH. But medical process is either metabolic acidosis or alkalosis. So when you come to pH, when you come to bicarb, pale sasa unasema kwamba hii ni metabolic, kama ilikuwa metabolic ndio unasema hii sasa ni acidosis au alkalosis. Vile vile unakwenda kwenye CO2 based on how it is, unaposema sasa hii sasa ni alkalosis au acidosis. Lakini unapoona na pH peke yake, kwa mfano umepewa pH, hii pH ni nini? Unasema hii ni acidemia au alkalemia. Lakini ukishapewa na CO2, then inapokuja ni ipi, acidosis or alkalosis. That's the time that will be, because now
You get it, right? Okay. Hi. Now, since you know all the things, see, the patient usually comes, okay? So I know there had been currently the trend that we forget to touch the patient. Yeah? We look at the numbers, okay? So always correlate patient, the clinical scenario of the patient presenting to the emergency department or to the hospital, and in correlation with the blood gas. Okay, so let me give you an example in my center. Every center is different. Okay, I've worked in a couple of other centers. So in my centers, like if a patient comes in the emergency department, okay, because I'm an emergency primary, so when they come in, okay, my nurse knows like they have to be done triage 1, 2, 3, 4, 5. Take triages like the patient has to stay at the emergency department or has to move to the outpatient. These are the process. And then if it requires to in the emergency department, the line access has been placed, the blood is drawn in the vacutainers, and immediately a blood gas is done. When a doctor comes in the 5 minutes, the blood gas is ready. So this is all the process. I'm not saying that you have to adapt to what I am doing, okay? So it's a time that you can develop over time. It's not like it can happen overnight. Even when I started, it took me like 5 years to where I am right now, okay? Or more than 5, okay? So coming to the case, okay? Now here, because this case is in kilopascal and we are more comfortable looking at millimeters of mercury. Our machines in Dar es Salaam are more of calibrated in millimeters of mercury. In other places in kilopascal. So I try to convert them into this, okay? So ideally you have to multiply it not by 8, by 7.5.
That's fair.
Yeah, so that's estimation, okay? So by looking at this one, okay, I'll be going very basics to you guys. I'll not complicate, okay? I want you to just interpret the basic things. I will not go into the depth of it.
Okay, there's alkalemia, I see.
Yep, all right.
44 with
So before going there, I just want to put a recap on that. Any part can become primary, and the other part can be secondary. Secondary in the sense that primary, if someone having primary metabolic acidosis or alkalosis, okay, so the lungs will try to compensate. If it is metabolic acidosis, means the bicarb will be on the lower side, isn't it? Okay. So what will the lungs will do? Will try to retain the carbon dioxide, to create a respiratory acidosis, as to buffer up with the metabolic alkalosis. Yeah. If it is metabolic acidosis, okay, primary metabolic, so the lungs will blow out the carbon dioxide to make respiratory alkalosis. Okay, just to buffer up alkalosis, buffering up with metabolic acidosis. We are clear, right? Yeah, as to maintain the neutrality. Okay, the pH to come to normal. Now, in the physiology, we understood that if the primary problem is the kidney, the respiratory takes, like, it happens within minutes to hours to compensate. But if the problem is lungs, to kidney to take over, it takes maybe not hours, actually it takes days to weeks. That's the whole thing of normal physiology. Compensation. Okay? All right, let's continue with this.
So, let's go, guys. This is 96. It's normal. Yes, he's 36, so yeah.
Okay. So metabolic. So if I have to interpret here, so I have to interpret the primary, you said, is metabolic alkalosis. Okay. Now, did you happen to see the PCO2? Yes. Okay. So the PCO2, is it low or normal? Actually, it's supposed to be not 40. It's supposed to be 40. It's supposed to be 40. Okay. Yeah, it's normal. Okay. So it's normal, right? So now, so is it now compensation part? Okay. So compensation will anticipate is supposed to be respiratory acidosis. Now, here I'll just make it a bit simple. Is it well compensated? Is it undercompensated or overcompensated? So what do I mean by this? Okay. So the aim of compensation is to bring the pH to normal. Okay. This is the way how you interpret, to bring the pH normal. Did the CO2 come to respiratory acidosis to bring the pH normal?
Here 40.
Yeah.
The normal range.
Yeah, but so ideally this would have been fort ingekuwa kama 50. Yeah, kwa sababu kama ingekuwa 50, hii pH ingekuwa 7.40 or 7.4. So where this patient lies, well, under or over? Yeah. We all okay? I won't go into the calculation. Okay. We are okay? Nikupatieni kesi nyingine?
It's for practice.
Yeah. I'll ask question.
With the compensation.
So in this case, you said if you have any metabolic derangement,
Yeah.
the chest,
The lungs.
the lungs are the ones to compensate.
Yes.
It takes a few
Minutes to hours.
So when you see such a case, means the lungs are not compensating.
Yeah, they're not compensating.
Yaani maana yake ni kwamba we have two organs. We have the kidney and the lungs. Sasa primary problem ndio kwenye tatizo ambalo tunaliona hapa. Tumeona the primary problem is from the kidney. So huyu lungs ambaye kwa sasa hiyo hana tatizo, anatakiwa afanye kitu, afanye compensation. So how wana compensate? It's either to wash CO2 or to retain CO2. For this case it was more of metabolic alkalosis. So lungs alitakiwa ku retain more of CO2 ili kufanya the pH irudi kwenye normal range.
Can I ask a question? The term secondary, I mean primary and secondary, how do you know it?
Okay.
So ili kuweza kusoma gas, kitu cha kwanza tunaenda kwa steps. Step ya kwanza ni kuweza kuplug pH iko wapi. Hiyo ndio step ya kwanza. Is it alkalotic or acidosis? Lakini
acidemia au alkalimia? Okay, hii tunakosea sana, tunakatwa maxi kwenye mtihani.
Ujue primary problem ya patient. Yaani usisome tu numbers, umuone mgonjwa. Unaona mgonjwa hivi, relate ninachokiona, unacho present nacho na my numbers. Iko ndo kikubwa zaidi. So ukishasoma where is my pH, unaenda sasa unasoma either CO2 au bicarb, any of it. Na yenyewe uweze kuiplug iko wapi. Hicho ndio itakufanya ujue where is the primary problem.
So you mean
huyu patient wetu, yes, kwa kutumia hiki kitu hapa. So tulisema pH ikiwa below 7.35 is acidemia and above 7.45 is alkalemia. And CO2 when it's below 35 alkalosis, when it's above it's acidosis. Bicarb ikiwa below 22 acidosis, ikiwa above ni alkalosis. Hii ndio tewe unavyoweza kusoma numbers na kusema iko upande upi. Sawa? Hiyo unatakiwa ujue iweko kichwani. Lakini ukija kwa patient, huyu patient anakwambia kabisa tayari patient with a history of vomiting. So tunapo vomit, gastric content inaondoka. So huyu mgonjwa gastric acid
inatoka nje.
Kwa hiyo mgonjwa wetu atakuwa more alkalotic. Sasa huyu CO2 ikabidi lungs aweze kuretain more of CO2 zake ili zile formula zikifanyika tunapata at the end weak carbonic acid.
Yeah.
Yes. Kwa hiyo itamsaidia zile hydrogen ions zitakazozalishwa kuweza kufanya compensation, kufanya pH yetu
pH iwe less than 7.45. So this is, you know, the process is all gradual. Na so kwamba of course kuna sehemu nyingine wanatoa blood gas kila baada ya dakika 10, which is a bit torturous for the patient. Unaanza kuchoma. You have to just also look at the gestalt and logically in representing the patient. Okay, so where the patient is going, and then based on that what therapy unatakiwa mpatie. This is only interpretation. Okay?
Yes. Sasa
kama tukiona kwamba mapafu yetu yana compensate, sasa tunapokuwa na metabolic alkalosis hatuwagi na mawazo sana, kwa sababu tunajua mapafu kuna kitu yanafanya ili kumeka pH yetu ikarudi kuwa normal, kwa sababu tunasema lungs inapofanya compensation mapema itachelewa kama ana lung issues. Kama na magonjwa ya mapafu na nini unaweza kusema tunategemea kwamba within hours hii inaweza kuresolve kwetu, siwe issues labda kuanza kumpa dawa na nini, sio acetazolamide kuanzishia.
I think kwa hapa for basic thing as a clinicians I know kama hii tunajua kwamba na vomiting kabla develop metabolic alkalosis, kitu gani tunampatia ili mambo iwe sawa therapeutically. What IV fluids? Yeah, RL you can give, or any fluid has chloride containing solution. Okay. Because chloride containing solution. Okay. I know Western world wana hydrochloric acid. Okay. Huyu kapoteza acid. Acid, chloride imetoka, so bicarb imezagaa sana, so unampatia but we don't give hydrochloric acid. We give what we have kama amesema RL or normal saline.
Normal saline is common.
Yeah, so you can give normal saline, as ile compensatory system yake usi overwhelm sana, ili usimumize compensatory system. Of course itafanya kazi yake, ndio maana the nature has given us to compensate, to give us compensation. Okay, so some patients, that's why tunasema kwamba kuna wengine watakuwa undercompensated, overcompensated, because if they go overcompensated they will also see a bright light and then go bye-bye. Okay, so we have to intervene. Yeah. So next case. Any questions again? Okay. I'll not go some calculations. Okay. All right.
Normal pH.
Unataka kuangalia. Okay, sawa, mna tabu. Hii azee ikae kwenye fingertips.
24, right?
24. Tuseme 25 hiyo, okay.
Equal share, so we have no, ni alkali jamani. Yes. Carbon dioxide is acidic in nature. Okay. And then the other one? My cup is 15. Econo.
Hi. So I know pH is normal. So unajua kuna watu wanaangaliaga when the C, they look at pH ni normal. Gonjwa iko vizuri. Hajaangalia vitu vingine. So
I think it's a compensated metabolic.
Sorry. Hello, Peter. Good afternoon.
Ujue sasa nani amefanya kitu.
Nakusikia lakini sijakuelewa. Sasa nikaribu rudia hiyo.
So kwa gesi kama hii ni vizuri badala ya kusoma namba hapa nikikuuliza why unasema it's metabolic or respiratory. Kwa nini useme hivyo kitu? Unaweza usiwe na jibu kwa sababu just umeona namba, lakini ukiwa na history ya mgonjwa itakusaidia wewe kufanya make diagnosis. Yani mgonjwa umjue
kama ni metabolic ama
yani alikuwa primary na nini. So inawezekana kwamba it was more acidotic, lakini labda kuna kitu kimoja kikafanya kazi ikafanya pH awe ndogo, au ilikuwa alkalosis mmoja akafanya kazi akafanya pH ndogo. Kwa hiyo lazima ujue, let's say tumeona mfano wa kwanza it was vomiting, si ndio? Kwa kama vomiting kwa mfano huo tutakuwa na vomiting.
Okay. Hapa ilikuwa nyinyi mniulize maswali. Kwa hiyo I was just testing you. Kwa sababu watu wengine wanasoma blood gas kumbe mgonjwa kafariki. No, ishanitokea. Alafu daktari anasoma mgonjwa yupo mochari. No, ishanitokea. So it's very important, So as a doctor, I ask the nurse or ask the patient ana shida gani mpaka akafika hospitali kwenye hali hiyo. Just subtle, so kwamba story nyingi sana. So it's a very important for you to could have asked me clinically. It's very subtle. Okay. So history: 40-year-old male came into the emergency department. While later he was vomiting a lot. He took some herbal medications. Now he's a bit lethargic and he's fast breathing. This is the information. Okay, now you can interpret. Okay, so hapa naandika primary. Okay, metabolic acidosis. Okay, now coming to compensation part. I know there is a calculation related to it. I'll not go into the details. Mtanisamee. Okay, so hapa unategemea respiratory alkalosis, isn't it? Yes, right? If it is acidosis here, you anticipate the lungs to have respiratory alkalosis. Now, is it well, under, over?
Tumeielewa hiyo vizuri. Why tumekuja hapa? Umeelewa? Kweli? Naona kuna maswali. Ni hivi. Amesema history. Patient alikuwa na severe vomiting.
Baada ya kumeza vidonge fulani.
Alimeza vidonge akapata severe vomiting. Lakini pia na nini? Anapumua haraka, sio? So maana yake ni kwamba kama alikuwa anatapika, it means amepoteza hydrochloric acid. Hiyo ndio cha kwanza. Sasa mapafu ikabidi sasa na yeye aweze kuexpire haraka ili na wewe aweze kulose CO2, kwa sababu ukiwa na more CO2 ataenda kwenye more acidosis. Kwa hiyo mapafu akaanza kufanya compensation kupumua haraka. Ndio maana tumeona CO2 zetu ziko low. Kwa hiyo huyu ni compensation, lakini primary problem was metabolic acidosis.
Kwa hiyo kwa sababu ni kudefine kama iko well compensated, under compensated, or over compensated. Then we look at the pH. The pH is your normal range. This is well compensated.
Nice. We okay, eh? Mpo vizuri, eh? I say mpo vizuri kwenye interpretation. Sawa. I say kuna swali, naenda another case. Okay. Scenario nyingine hii hapa. Najua ipo kwenye kilopascal, nimeconvert to millimeters of mercury. Okay. 20-year-old male referred from other hospital, newly diagnosed diabetes. Okay. Alipewa some fluids while kabla kufika kwetu. Okay. Then he's lethargic and hyperventilating. Hyper.
And that hyper
like earlier answer, so kwetu. Hyperventilating. He's tachypnic and using accessory muscles.
Diabetic patient. Non-diabetic.
Yeah.
So you can just thread it in the wire, but oh, okay. All right. So now you've got to put the dilator in. Okay, but don't go all the way in. Perfect. Beautiful. And now you just have to gently do it, okay? But we won't do it this time. Yeah. All right. Good. That's fine. You could probably stop there now. Yeah. All right.
Then I move it out.
Yes, let's move it out because somebody else is going to have a go now. Yeah, beautiful. And we have a thing in our hospital. You can pull the wire out now. Somebody else will have a go.
Okay.
Yes.
Pull the wire.
Yes.
So after here, I just put the catheter.
Then you put the
Then
catheter
I
in. Yeah.
test.
But remember, your wire has to come out at the end here before you put the catheter over. So we have a checklist. Again, we have another checklist for central lines. Your wire, you always have to show somebody, I've taken out the wire, okay? Because people have forgotten wires in there, and we've had to have surgery, they've had to have some big operations to pull a wire out of the patient. So never, every time we've now got a checklist to make sure people remember to take the wire out, okay? Good,
So when
okay.
you enter this, the wire
Yeah.
can come on one
Yeah.
of the either.
So you can try it now. Why don't you try and thread this over for me? I'm going to unclip here. Okay, now before you go all the way to the skin, you can't go all the way in, just stop there. Now with this finger, pull your wire back. Yeah, just pull it back. Okay, just keep pulling it back until you see it come. Yeah. Yeah. Okay, good. See, it's coming, it's coming. So only until it comes out here. Wait, nearly stop. Now you hold with this hand. Okay? And now with the other hand, you just slide the catheter over the wire. And it goes all the way in, okay? Good. You won't now because we haven't dilated. Okay? And then once it's in, you pull the wire out. Okay? Very good. There you go. You've done your first central line.
Trying real life. I really wish to know this. I really wish to put every day. Yani I assume napata central line inabidi kuita hiki surgeons.
Okay, who's next?
It's too sad. Yeah, sisi huwa wanapelekea surgeons na kuna
All right.
asipokuwepo ndo naomba tu surgeon.
Okay, who's next? Are you turn?
Ila
Yeah.
I really wish to do it. Huyo ni mannequin mwenye sweat.
Do you have cannulas in your kits?
We have the no more central line. The one,
These ones?
no,
No.
the one with an introducer for the guide wire. So a special needle, the big bore needle.
Oh, okay. But no cannula you can leave, so it's just a needle only. Needle only. So a bit like this needle that's here. Just this needle only.
Yes.
So you only have this.
Yeah.
This type, but bigger.
It has an introducer for the wire.
Oh, okay.
So
Oh,
you don't have to remove it. You just introduce the wire.
wire.
Then you take it out.
Okay. Okay, so yeah, slide the white all the way before you pull your needle out. Good. Wonderful. Now you pull your needle out. Yeah. Okay, good. And yeah, excellent. And just put that, yeah. Just gently aspirate so we check we're still in the vein. Look, everybody's watching with intent. It's not, so it's pulled out, yeah? So that's common, that can happen, and that can also happen. There you go, now you're in the vein again, okay? So when this happens, obviously I'm not going to teach you what to do. Normally you just pull out and do it again. Okay, that's what we would normally do. Okay, so the reason I'm teaching that is this can happen with the needle as well, because if you're using the needle instead, yeah, your needle, you can take that out, just pull that out. Your needle, why don't you try the needle for me and show me, yeah, and we'll show you. So, yeah. Okay, and always have a bit of negative pressure on your syringe when you're going in, yeah? Just so you know that if you hit it, you'll know straight away. There you go, okay? So now hold your needle. There's no cannula, so you just have to hold the needle and take your syringe off. Okay, okay? So you need to hold it at the patient like this. What I would do, I would hold like this, yeah? If I've got a needle only, I hold, my hand is on the patient like this, and then I'm doing like this, okay? So that my needle is not moving in and out at all. okay, stabilized to the patient, and I've got a good grip here. Because now when I take this off and I try and put a wire in, this can easily, if you're holding up here, it's just going to go in and out, okay? And you could go in and end up in the artery and not know, and you just put a wire in, or you could come out and you end up outside the vein, which is why a wire won't go in. So if you've only got needle only, when you're taking the syringe off, just really stabilize your hand on the patient and the needle. So this does not move anywhere, okay? No in and out. Yeah, good. Okay, why don't you try threading? I'd actually just check if we're still in the vein. We might not be in the vein.
So if you are using the needle,
Yeah.
is there need of dilating?
Yes, you still need to dilate. Ah, beautiful, we're still in there. Yeah, because the needle is not so big. The needle is similar to this. All right. And if you don't have cannulas, there's probably no point me teaching you cannula, so maybe we can just try needle only.
No, sometimes we can use cannula.
Okay. So it should go nice and smooth. And usually I go just to the 2 marker point. Okay, so not all the way in. And whenever you're threading a wire, you've always got to be keeping an eye on your ECG, okay? If you find that you're starting to get ectopics or a little bit of arrhythmias, it means your wire's in the right heart, and just pull back a couple of centimeters until the ectopics disappear, okay? Good. So now, you hold your wire a bit. Yeah, beautiful. So just gently hold your wire while you're pulling your needle out. And once your needle's completely out, just pull out a bit more so you don't hurt yourself with the tip. Yeah, good. And then pop it straight in your tray. Okay. And then normally you dilate. Okay, do you want to just show me how you put the dilator on before I let you pass on to somebody else? Yeah, yeah. So usually we put a gauze at the entry, and then yeah, it's always nice to bend the wire a bit so it's not out in the air somewhere. Yeah, there you go. And just you have better control. Beautiful. And then normally twisting when you put it in. Okay, gentle twisting. Yeah, but don't go all the way in. Okay, good. Happy? Wonderful. All right, that will do. Okay, who's next?
Me.
Okay, so you're going to do the whole line. Okay. Okay. Do you want to have a go at doing the whole line, and then the 2 of them can have one more practice? Yeah.
Okay.
Yeah. Go on, because you're doing the whole line. So why don't we give you a bit of time, and then we can get the other 2. So yeah, so you're going facing this way. So I always stand this side of the patient for the very reason, just how you are, but I stand like this. Okay. So automatically I'm facing this way. Yeah. If you come like this, you're going this way. Yeah. And that is the wrong way to go. Yeah. So stand a bit that way so you know you're going to aim your needle out. It's just little tips you learn as you do them. And always have a bit of pressure on your syringe, yeah? Negative pressure when you're going in. So negative pressure on your syringe. So I would hold the needle like this, okay? So that as you're going in, you're putting a bit of pressure like this. So the minute you hit the vein, you're going to have blood coming back, okay? So just hold it that way for me. So yeah. So you don't need to actually have negative pressure yet, just hold it like that. The minute you're going in the skin, once you're in the skin, then start to just put a bit of negative pressure on the syringe. Okay, go through the skin, and now just have a bit of negative pressure on that syringe, like you're pulling back a bit. There you go. Okay, the minute you aspirate, stop. Now, with that hand, hold your syringe nicely into the patient, and then undo. Okay, I've got this ready for you. Yeah. Okay, good.
Yours gonna be okay.
Should go nice and smooth. So, and then what I usually do, because I want to see the markers, I just pull this bit out a bit so I can see the markers, yeah? So you know what's going in. And then keep going until you get the 2 markers. I don't know if you've got the 2 markers in yet. The 2 lines. If you've got the 2 lines, yeah. Is that 3 or 2? 2, yeah. So I go up to that point, yeah? When I see that here, then I pull out the rest, yeah? Okay. Okay, so you can pull this out, yeah? Usually I'll probably put the wire in a bit more until this 2 is right near there. You can just push it in while your needle's still there. So the whole time you're doing this, you've got to remember your needle has to be really still. That's why I like the cannula. There's just nothing in the patient and my cannula's in the vein, yeah? You cannot move the needle. Okay, that's enough. Yep, plenty. Now, while you're holding the wire here, pull the needle out. So just gently pull the needle out, but hold on to your wire. So if you hold on to the wire and gently pull with that hand, gently pull your needle out. So just hold the wire so your wire doesn't come out. You don't have to push the wire in, and then once you get enough there, now change over. Hold the wire down there. Yeah, with the gauze. There you go. And then the needle can go straight into your tray. Yeah. So I tend not to push the wire in more because you start to get ectopics.
Okay.
Okay, good. Now, your turn, because you're doing dilator, so do you want to do the whole thing? It's all a bit fiddly initially. It's always fiddly initially. Once you've got that muscle memory, it becomes very smooth. There you go. That's the hardest bit, I find. It's like threading a needle, isn't it? Good. Now, nice gentle movements. Yep. So normally you make a nick in the skin, like a little cut in the skin, okay? But we don't have a blade. And sometimes in skinny people, you don't need to. So just go all the way in a bit more until you get a second give. I think you need to give it a little bit more. There you go. That's probably enough. Okay, normally you feel a give, which in this one you're not going to feel. Okay, good.
So
now, this, just make sure this is nice and smooth here. It's still, so just let go here a bit of pressure. Just make sure it's going in nice and smooth. Yeah, great. Now, gently pull your dilator out. Yes, Mweka? Just hold this.
Sorry, I'm just taking.
Sure. Oh yeah, of course. Great. Okay. So that now, and now you've got to put the line in. Okay, so you can give yourself a little bit of ease. Okay, it's your line. I'm going to undo the clip. Yep. Oh no, they're making you laugh. Don't worry, I have people watching me and I just cannot, I cannot, it's moving everywhere. Okay, wait, don't forget.
I forgot.
Yes, if there's one thing you're going to learn today, don't forget the wire in the patient, okay? It could be the most beautiful central line, you cannot leave the wire in the patient. So all the way in, so you just hold it, and this should just slide over. No, you hold here, and it should just slide over, okay? So don't pull your wire out. Don't pull your wire out. Just push this in gently like this. You're just gently holding this and just pushing that over your wire, okay? It should go all the way in because you made a nice tract with your dilator, okay? So usually it should go in. I think we might have come out of our tract now, so that's why that's happening, okay? Yeah. It should just go all the way in nice and smooth. We're probably in a false tract now, I think. Oh, there we go, are we? No. So that's not going to go in. Okay. So I think we're a bit out now. So if I just hold on to this a bit gently. I think there's a kink. If there's a kink in the wire, that also happens. Okay. So normally you just gently hold on to this. You don't have to pull on it, and this should just slide over. It's obviously not wanting to now, so. And if it doesn't, don't force it, okay? But normally it should go all the way in, and then you just take it out. So let's just pull it out. I think it's just tearing as well.
Okay.
See, there's a kink. Once you get a bend in the wire, it never goes in. Yeah. So, oh yeah. See, 2 bends. That's why. Yeah. And that happens because we're practicing so much.
Yeah.
But when you're doing it on your patient, it's going to be a new wire nobody's ever used before. Okay. All right.
So we've got some
I
tips.
think we forgot something.
Yes.
Infiltration with
Local. Yes. Good point. Absolutely. Do you guys use it on everybody, lignocaine?
for
Awake patients, yeah. Okay. So we did forget a step. If your patient is awake, lignocaine. Numb it first, then do it. I don't in my asleep patients, but some people even do it in asleep patients. Okay. Yeah. Local anesthetic. Okay. All right.
So you can use, what's the best, the needle or the cannula?
For me, I say cannula.
Cannula is the
Because it's safer. Because you also, that cannula is long, huh? Look. So you get into the vein But if you don't have it, it doesn't matter. But see, the vein is only this deep. Yeah. So then I've cannulated the vein, and then this whole cannula is in the vein. So now I've got this much in the vein. While if you just use needle, you've got the needle tip in the vein, nothing else, and it's dangling while you're doing wire, while you're taking dilator in and out. So the risk of dislodging is much higher.
It has to be this special cannula for.
We use large bore cannula. Oh, there is a special cannula.
This comes with a kit.
Come with the kit.
Comes with a kit.
Ours doesn't come.
Yeah. So if it doesn't come with a kit, then you have to just go with what you've got. Sometimes, which I don't want to tell you something that, you know, I know what I would do, but if I didn't have a cannula, but I don't want to like make you break rules.
When you're doing central line, do you use heparin?
No, no heparin. No heparin. No, only time we use is dialysis catheters. Dialysis catheters. We flush at the end. Only at the end we flush with heparin. Yeah, yeah, yeah. Are you right or left-handed, Fatima? Are you left-handed?
I'm right-handed.
Ah, yeah, wow. You look very good there with your opposite hands. Okay. And just remember, never inject back into the thing.
Yeah, you use your dominant hand.
Yes. Yeah, good. And then with that hand, you stabilize your needle with that hand. Yeah, and then you undo. Yeah. So everything you're doing proper, you're doing with your right hand, and your left hand is just stabilizing your needle. Yeah? Your wire. Yeah. Now the wire's got a kink in it, so you're not going to be able to even put dilator, but you can at least try and thread the wire. Yeah.
So I have to push it
until there's usually 2 marks, 2 black marks. So keep going in. Yes.
Sorry. This one. Thank
ina transmission speed, speed ya kutransfer information ni kubwa sana, ya haraka sana. Jamaa wananiletea mimi saa hizi ngati nishachoka.
Dakika ngapi tu? Dakika 3. Sasa tunaenda nchi.
Hello? Eh? Welcome. Kaeni kwa hivi. Yep. Okay, mko wanne? Au ni? Read the scenario. Yes.
mechanical ventilation troubleshooting. Your patient was admitted to ICU 4 days ago with asthma. She is intubated and ventilated on volume.
Sogea kwa
Scenario. Your patient was admitted to ICU 4 days ago with asthma. She is intubated and ventilated on volume, preset, assisted control ventilation. You have just finished attending to the patient mouse care when the ventilator alarms. The screen ready high-pitched inspiratory pressure. Question: what does this alarm mean? What is your first cause of action?
So those are the questions. Jacqueline, what does the alarm mean?
Alarm iliyotoka ni
Inspiratory pressure.
Don't focus here. The question is just there. What does high peak inspiratory pressure? Yes? Huku.
Hapo sawa. Unaweza kukaa. Hilo nini ndio inabidi tuliona. Sawa,
But I think high respiratory pressure, the machine is using a lot of pressure to ventilate the patient.
Okay.
basically there's a lot of resistance on the ways, right, to take the air in. Can I make that interpretation?
We have a high peak. What does high peak inspiratory pressure means? What is peak manake nini?
There's a peak, high inspiration.
Peak, what's the meaning of the word peak itself? Top. So like, in other words, it comprises of the total. Come on, there's high total pressure.
Peak and everything else.
Sawa. Are we all together kwamba tumeelewana? High peak inspiratory pressure means the total pressure the vent is using is high.
It's very high.
So we need to take some cause of action to actually identify, assess, treat, reassess, treat. So the next question comes, how are we going to solve it?
Cause of action.
Wengine hapa hamna majina yenu, nashinda kuwaita.
Sasa, if I remember well,
Wewe ndio umeitwa pale na nurse. Daktari, this is the scenario.
bado. Sasa in this scenario, kwa sababu lazima tuanze kuangalia shida iko wapi. Because we have three components to look at. We have the ventilator itself. We have the ways, the structures that are coming into the patient, and the patient.
And the patient, good. So where would you start?
Disconnect, tuna mpampu, then tunaangalia shida iko wapi, si ndio?
Good. So it's a teamwork. Okay. But then where you would focus with? You'd want to focus with the patient kwanza. So, but it's generally a teamwork. So upon assessing the patient, how do you go about it?
Helping the patient or assessing the patient.
Yeah, assess. We want
There's a problem or not.
we want to assess the patient now. ABC, good. So on A, what are we looking for?
If the airways are patent,
Okay, if the air is a pattern, good.
breathing, if the
Still on airways. If the secretions,
patent secretion, whatever.
okay. So kinking of the ATT, secretions or mucus plug in the ATT.
What the word?
Kinking, ATT, kink. Where's the tube up? This.
That is what we call kinking.
Kink of the tube. Au biting the tube. Mgonjwa ameing'ata this. Au imesogea to the carina. So you actually look for the depth. Sindio? So we're done with airway, breathing, Breathing of the patient. Breathing tutambia nini? How will you assess breathing? Chest rise. Iwe nini? Symmetrical.
Symmetrical.
And if you are asymmetrical, what would that tell you?
Ile tube inawezekana imeenda
One side?
one side.
Okay. And if you have corrected the depth and still it's asymmetrical, what will it tell you?
Pneumothorax.
So there's a pathology in the lung, either lung consolidation, lobar collapse, or there's tension, pneumo, or hemo. Yeah. But also you assaultate to hear this respiratory coherence. Okay. After breathing, circulation, good. How will our circulation help us?
So circulation,
If the patient is hypotensive,
there's hypotension, and yeah. So we basically check at the pulse or the central heart rate, right?
but also if the patient is hypotensive and on symmetrical chest rise and decrease their entry on one side, what would you think of?
What the name?
What about tension pneumo? Okay. So we are done with assessing the patient and everything is okay to the patient. Now we want to go to the other component. So we are going where? The breathing circuits. What about the circuits? Madam.
Ukisema breathing circuit maanisha hizi ile pia. Okay.
What about the breathing circuits? What could go wrong here?
They can either have water from the humidifier,
So,
they can have, it can kink also, inategemea na-
okay. So some breathing circuits, the breathing circuits are coiled so that to avoid kinking. So iwe ngumu kukink, but some of the breathing circuits can be very thin and they can eventually kink even by themselves. But also the key component here is that these breathing circuits should be connected into the humidifier. So supposedly you have a moisturized air going to the patient. Unajua ile hewa ya mvuke mvuke, kwa hata umeyuko kunaoga mvuke mvuke unakuta kuna maji yanachuruzika, sio? So like utakuwa na maji kwenye breathing circuits. And this ndo kazi yake, water trap. This is a water trap, so that all the moisturized air water comes down towards the water trap. And here the same, sindio? Ambacho hiki kikijaa, you can actually remove this and clear the water and return it back. But supposedly kimejaa zaidi, and someone did not clear it off. So the water in the breathing circuit will cause what? High air pressure. Sindio? High peak pressure. Or supposedly hii trap imekaa hivi.
Inaruhusu fluid kurudi nyuma.
How?
I mean, like inaruhusu.
Kivipi?
Kwa hivyo niliweka hapo, yani ukiweka maji inaruhusu kurudi nyuma ama ina some sort of valve na
No, haina valve. Maana nimesema suppose likiweka kama hivi, maji yanakaa. So maji yatakuja kwenye mgonjwa. And what about the other side? Maji yatakuwa hapa. So sometimes this water trap unakuta zimekaa kwenye kitanda cha mgonjwa badala ya ku under gravity. So you're done with the breathing circuits. You're going to your vent. So what are the things that you check on your vent? on a ventilator settings. Remember the balloon model?
Yes.
So the resistive component, we have what and what? Flow and resistance.
And resistance.
Okay, resistance, you have cleared that out.
Yeah.
Flow.
Tidal volume.
Okay. So if you have higher tidal volume settings, or you have shorter inspiratory time,
increase pressure.
So what will you do, Selina?
So I will kuweza kureduce nani resistance.
Okay, good. So we select and reduce the tidal volume. Anything else? You want to reduce the tidal volume? Siogope. VT is here. Then use the knob to reduce it.
Tidal volume weka 500.
Supposedly it's an adult male, but you haven't confirmed it.
Okay. And then inspiratory time.
Inspiratory time, supposedly if it is too short, you can balance it with your E ratio. So, any other setting that you can actually look on your vent? From the, what about the alveolar component, the elastic component?
That's where we do the inspiratory pause.
Okay, so you wanna do the inspiratory pause? You can do it? What, how to do the inspiratory pause? You can do it?
No. I don't even experience on that.
Okay, so you go to the tools, then you hold. So inspiratory hold active, then it will give you the P plat, which is 15. So suppose you have a total pressure of you have done your inspiratory hold and the P plat is 25. The pressure plat is 25. What does it tell you? Total pressure is 30, the P plat is 25. What does that tell you? Tijaku.
Na swali hapo jamani. P plat inamaanisha nini kwanza?
Pressure in the alveoli.
Okay.
Sawa.
25.
So yeah, you can think of gas trapping models. What? It can be compliance. The compliance has decreased.
Vitu sema na compliance nini? Ile kualau kama rigidity fulani.
So if the P plat is high compared to the P peak, it means the alveolar component has an issue. And not the resistive component. So you want to check on your chest wall rigidity imepungua, there's decreased compliance of the lungs. So it's basically lung pathology. So you can either do a chest x-ray to actually rule that out. So, yeah. Okay. Next scenario.
Reviewed the patient and decided to wind her into continuous mode of ventilation. You change the mode to PSV and monitor the patient. After a few minutes, the ventilator begins to alarm low MV. The ICU team reviewed the patient and decided to wind her into spontaneous mode of ventilation. You change the mode to PSV and monitor the patient. After a few minutes, the ventilator begins to alarm low MV. What does this alarm mean? And what is the first cause of action?
So my first yellow your mode. Then you mean sorry my name. The mode is continuous mode.
PSV. Pressure support.
Then you can decide to change kwenda kwenye hiyo and monitor the patient. Baada ya few minutes, ventilator ikaanza kwamba kuna low MV.
So what does the alarm mean? Low MV. Yeah? What does the alarm mean? Low MV. Do we know kwanza what is MV? Ed. Eh? So, minute ventilation. Minute ventilation. How do we get it? Tidal volume times respiratory rate. So we're all together. So if minute ventilation is equal to tidal volume times respiratory rate, when the minute ventilation decreases, what does that mean?
This is kuna increase, kuna decrease. Respiratory rate or tidal volume.
Okay. So there's a decrease in respiratory rate and tidal volume, or among one of them. So tupo wote kweli? Mnaka aibu na mnashangaa sana vent. Task fixation, eh? Okay. So, what's the question? What is your first cause of action?
Maybe increase tidal volume or respiratory.
So she wants to increase one among them, either tidal volume or respiratory rate. How do you do that?
To increase tidal volume.
Oh, that's the spontaneous mode. I think you change to more
So first you'd want to know what's the component that actually decreased. Is it all of them or is it one of them? So mfano, the tidal volume is low, and on your on pressure support ventilation, but the patient anachochukua is not adequate, but is breathing fine. So what do you think that you can add to support your patient?
10 more minutes.
Okay, I'm giving you the answer. Utaongeza the pressure support. Sawa? Alikuwa na pressure support ya 10, tidal volume anapata is 200, which is not enough for him, so you can increase pressure support to increase the tidal volume. But then suppose it's the respiratory rate which is low. The patient anapata apneic moment. What will you do? You change the mode. Unaacha the pressure support mode, unaenda kwenye either SMV or control mode, because your patient is not breathing, and this is the mode that you need for a patient ambaye ana breathe adequately. Sawa?
Umezungumza Kiebrania hapa. Sijaelewa. So we have pressure mode and volume mode. Because yani nishakaribu vitu vitokea jana. Umetamka kitu kingine sasa hivi.
Pressure support mode. So the support modes, jana mlijifunza the control modes na the support modes.
Nakumbuka hiyo lugha sikumbuki.
So we have the control modes na kuna the support modes. Control modes unamwekea mgonjwa ambaye hapumui.
Yes.
Sawa. support mode tunamwekea mgonjwa ambaye anapumua. Unataka umsupport. Sasa huyu mgonjwa alikuwa amewekewa support mode.
Shakumbuka.
Sawa. Lakini amekuwa sasa hapumui. Kwa hiyo
control mode.
Haya. Another scenario, the last scenario.
You have just repositioned your patient when the monitor begins to alarm. You have just repositioned your patient when the monitor begins to alarm. The patient's oxygen saturation is really 88%. The patient is intubated and ventilated on spontaneous mode ventilation. Question: what is the first course of action?
Okay, so what are the issues come up with repositioning of patients?
Cha kwanza hapo tutaangalia kwa sababu position maybe intubation imetoka.
You mean the tube?
Tube.
So tube displacement.
Yes.
Now
itasoma 88.
Okay.
Yes. Cha kwanza hapo ili uweze kufanya confirmation, kitu cha kwanza ni maybe unaweza ku as a team, as a team unaweza kuangalia, unaweza kuassess tube iko in situ au tube iko in situ au not.
Correct. Yes. Correct. So you guys will start approaching the patient and do your ABC. So in your airway, you want to make sure that the tube is correctly placed, and you do your confirmatory ways, which are 1.
Tube is implanted.
How would you know?
Assessing.
So through assessing, what are you assessing now? What are you doing? How would you know the tube is inside?
How do you know the tube is inside?
Okay.
Listening.
Okay, before listening, how do you start? Won't you look?
No, to do observation,
you want to look at the tube depth?
Yes.
So you can look at the tube depth.
Yes. Kumbuka kwanza lazima kuangalia ilikuwa ni urefu wa hiyo.
The depth.
Kama ndio hiyo ambayo unaangalia unasoma pale kwa ngapi?
Depends on the tube size number ulioweka.
Sawa, so you don't know that, right? Kwamba hii imeingia kwenye right depth. And then what I would do after that, I think try to listen into the lungs. If there is, I don't know. This ndio nitakuwa na mpampu mgonjwa, si ndivyo? Namfanyia
even unataka kusema. So you bag the patient, look for the chest rise bilateral, you assaultate, you look for the capnography. Simple.
Capnography?
Capnography is something new.
No, to me it's new.
But simejifunza jana the capnography.
Sikusikia neno kwanza. Sikusikia. Oh, inaenda yellow, inaenda okay. Majina hayo jamani.
Sawa. So, okay, make sure mkiondoka hapa mjue ways to confirm the tube placement. So, those are very simple ways that you guys should actually know them. So, the next step, tunamaliza airway, tunamaliza breathing. What else? What else could be wrong from repositioning of the patient? What's the next step after breathing? Circulation.
Yeah.
So what?
Pressure is for the pulse rate.
What should we check on circulation after repositioning?
The circulation. Let's check the heart rate and the pulse.
Blood pressure, Our patient saturation in Asoma 88 after repositioning. What else could go wrong during repositioning? Kwenye circulation part. Okay, what if the probe imetoka? Au imekaa pembeni? Pulse oximeter probe. Tunawaza mambo makubwa Any question? Madam nani naitwa? Emi na?
Rehema Lamek.
Rehema Lamek. Mmetokea hospitali moja?
Yes.
Wapi?
Thrive Care Clinic. It's in New.
Thrive Care Clinic. Iko hapa Dar es Salaam. Yeah, ndio imeanza. Mbali. Is it a big hospital?
No, it's small. It's 13. By the way, nitawapa some flyers there kwa ajili ya
promote the hospital
process.
When HR. Okay. Sawa.
Kama unachukua video kwa sababu ya kufanya. Umeona kama hiyo fulana?
Thrive Care. Okay. Sawa. How to connect this machine? Jana uko hivyo?
Kuna vitu vingine
no, hiyo ilikuwa ni station ya jana.
Yaani unajua shida ni muda.
Muda ilikuwa issue.
Kwa sababu nafikiri tuliopewa hapa tukienda kama wale ambao wana practice then it becomes easy. Mfano kama sisi pale Thrive Care, we have these machines. We have not started to use them.
Wewe waonyeshe nzia how to connect the machine. Na najua huyu ni majengo yako. Yakuna
Zunguka. Shika hii hapa. Shika hii. Zunguka huo mti hapo. Chap kwa haraka. kujaribu kitu nyingine. Unajua zamani tulikuwa tunafanya hivi. Zamani ulikuwa unapewa kabla ukienda nje utafute sehemu ya kulala, utakula nini, nimejua 60,000. Sasa hii hapa hivi ni bei book nimetoa hii ndio nakupa 10 ama 15 nakupa 15 ni pesa hiyo. Lakini hoteli ni hospital sababu ni kwa okay. Amona kutoka hiyo clip. Right. Oh, sawa. Asante. Pocket yake ya kitu yake ndani. Hello. Hello. Hii hapa utawa. Where do you want to keep it? Nishatia. Yeah, but okay. Hili Dr. Mwezi? Utabaki wapi kupresent?
Kusimama?
Yeah.
I think I'll be standing here. Hapa. Across here. Yes. Okay. Is it going to be full? Full screen. Itakuwa full screen here.
Yeah, this is just for recording purposes.
Okay.
This one will be your screen, like this.
Sawa.
This is just like inaonyesha hivi.
Okay. Umesema? Check. Dr. Maynard, how are you sir? Mzima?
Yep.
Mimi naitwa Anderson. Sasa mimi ni supply hivi vitu unajua ni vya department ya kwako. Hivi HMWs nini?
Ni supplier.
Mimi ni supplier.
Okay.
Yes. Sasa sijaweza kuja kutembea KCMC bado. So nilikuwa naomba namba yako alafu when I'm coming to visit mimi tuta communicate. Huko department ya anesthesia. Oh. Sawa. Nitakuja.
Wewe kampuni gani?
Mimi natokea Janst. Lakini vifaa vyangu sana vinajulikana kama vya intersurgical. Ndo sisi tunatengeneza iGel hizo nimesikia ukisema hizo they are very critical, inahitaji training kabla mtu hajazitumia. Yes, tu LMAs. Alafu na HMS nzuri. That manometer, ile manometer ya kupima the cuff manometer. Nayo vitu kama hivyo. Mask hizo za kumlaza mgonjwa. Very nice masks kama hizi hapa. Mara nyingi wanatumia zile za kuinflate kwanza. Yes. So sisi ndo tuna supply hizi hapa za muundo. So maybe after some time nitakuja kutembea KCMC. Alafu tuone. Nitaku WhatsApp doctor. Ina WhatsApp wewe? Okay.
I think I would want hizo manometer.
Kumbuka naona kama that is my number. This is Anderson. Yes, that one. Yes. Anderson. If possible, are you when uko around mpaka lini?
Anderson Maina.
Yes. Anderson Maina.
Of course, Anderson Maina. Kampuni gani?
Jansti ama Intersurgical. Ika Intersurgical.
Because sisi hospitali zetu tumeweza kupata vitu donations.
Donations hivyo mnaletewa hizi premium items
Very rare that we buy, lakini sasa hiyo manometer cup.
Hello Taslim.
Something that I'm interested
in. Yes, I'm talking to one of the doctors. They are finishing up the workstations with the workstations, and then they are going to come back. I think I'm going to mute first. I think in the next 10-15 minutes. Okay. All right. Thank you. Bosi ananiambia sauti yangu iko kwenye YouTube. Ananiambia naisikia. YouTube ananiambia ananisikia sauti zako. Submit now. Asante. Hello, how are you?
I'm good. How are you?
Good, good.
Thank you.
I haven't seen you today anywhere. Ulikuwa umejificha wapi?
I'm still there.
Okay.
Same row.
So excuse me. Is it okay I take your number after this? Alafu maybe we can communicate tuone the way our items are getting to you. Is that okay?
Yeah, is Shifaa. Are we?
Uko Shifaa hapa?
Yes, I'm
Oh,
Shifaa.
sawa.
Dr. Nisa.
Uko department gani?
ICU.
Emergency.
Critical care.
Okay. Actually, I have Dr. Moises number, nina number ya Munir, Dr. Kim,
Yes.
all of them. So I'm pushing nione kama watakubali, but they're saying your prices are quite crazy kidogo. But we'll see.
We'll see, inshallah. They'll talk
Inshallah.
to the management.
Okay. So, thank you. Chief, wewe uko tayari? Eh? Amesha mute. How soon? Nadhani amemute. Mimi nichukue chapo alafu nije tu present kidogo tuondoke sasa. Hiyo kwa presentation kidogo tu. Is not team. The only day you can see. Watu wa Saifike wanasema wanataka kupewa manomita for free sample.
Watanunua wenyewe. Sasa
manomita la moja. Nataka nipige sote hapo. Sasa nikupa. Unakita ngapi?
Zipo mbili koroji.
Mbili.
achana na materi yale na nini? Baba yetu inteli ina kama nne maana ni kama mfano
kama wanaweza kuchukua huyu anaweza kuenda mbili kwa theater ama one for each theater, alafu moja au mbili za ICU na emergency.
Hapo jana si alitoka wapi bana?
Tokea kwa hapa na kuchukua picha.
Yes, ready. Yep.
Is that on?
Yes. Umeiwasha.
Umeiwasha?
Yes.
Ngoja
Haya.
say something.
Hello. Hello. Hi, boy.
Let me just.
Okay.
So, ladies and gentlemen, this is the final talk of the hour, after which we are going to give certificates to the participants. I really hope that you learned something new, and whatever you have learned, you will practice it in your institutions. So this workshop, the food that you ate, was sponsored by Janssen. So the food that you ate and the event that happened, it was sponsored by Janssen. Janssen Healthcare are linked with intra-surgical. You have seen some of the equipments that he was showing around, Anderson was showing. And today he wants to use the equipment and teach us about safe airway management. So he's just going to take 10 minutes of our time. So please be attentive and go back to your institutions, especially to your procurement department, and advise them that it's better to have quality stuff than to have cheap stuff which can be ruined in a day or two. So welcome, Anderson.
Thank you, Dr. Shikia. Hello, everyone. Good afternoon. Tumeshiba vizuri? I am going to take just a few minutes. Basically, hivi vitu ni vitu ambavyo you passed on my workshop, on my workstation yesterday, and I demonstrated how they are used in a clinical setting, okay? So again, my name is Anderson, and I am from Janssen Healthcare. We are a pharmaceutical company based here in Dar es Salaam. We supply medical equipment, consumables basically, for anesthesia, critical care, and emergency, okay? So basically what I'm going to do, I'm going to go through some of our items, the basic ones, that are basically aimed at increasing safety when you are doing airway management, okay? And if obviously you are the a study by that was conducted at Muhimbili. At Muhimbili, yes. Okay. Okay, thank you. So this is a study that was conducted at Muhimbili to determine where are these cases coming from, okay? So they collected swabs from different surfaces in the ICU, in different areas in the clinical environment, and they found out that up to 48% of those swabs from those different surfaces, they had microorganisms, that they came out positive of a microorganism. Some of those microorganisms, they are gram-positive microorganisms. 69% had gram-negative isolates. About 30% had gram-negative bacteria. All these bacteria, they end up causing what is it called? The resistance to medication, right? So what you have to do is to ensure that your environment or the devices that you're using are optimally reducing the rate of the possibility of infecting the patient by at least maximum, okay? So that tupunguze hizi cases ambazo they are reading up to 30% in our countries. Sawa sawa? So what are the effects of having the patient developing hospital-acquired infection? They end up staying in the hospital longer, right? They end up, some of them may actually die because of those infections. They may develop disabilities. They may develop antimicrobial resistance. And then if they stay longer in the hospital, that means they are going to pay more, right? So for us, what we are trying to do is to reduce these cases for the better of our hospitals and our patients. So, okay? So Intersurgical have come up with this breathing circuit. When you are unamventilate mgonjwa, they have come up with this breathing circuit. It's called Silvanite breathing circuit. This one. So this breathing circuit is Silvanite. Now it means that it has silver ions on the surface of this circuit and inside the circuit, okay? So when obviously you are coming into the hospital, umetoka nje unakuja kumwangalia mgonjwa, you end up touching the breathing circuit. So the breathing circuit is in contact with the surfaces of the hospitali, ambazo we have seen they are most like 50% chance that they are contaminated. So what those silver ions do is that they deactivate those microorganisms so that you do not touch those bacteria from here and you transfer them to another patient. So this Nini is recommended for use up to 7 days, okay? So they have tested it and found that up to 7 days, they collected swabs from this circuit from day 1 to day 7. It was on a single patient, so I have to say this, on a single patient. And they, at the end of the experiment, that is 7 days, they did not find any microbe growth on this breathing circuit, okay? So that means that you can use this up to 7 days on a single patient, okay? And I know for our hospitals, we like to reuse, right? We like or we have to? We have to. So, so if you want to reuse this, then I would recommend that if it's on different patients, you can reuse up to 7 days, and only if you're using a very good filter. You do not have to wash it. You can use it on a different patient because there is no microbe growth on this bacteria up to 7 days. Sawa sawa. But then after 7 days, I can't guarantee you. Okay? Sawa sawa. So this one is good, especially for our referral hospitals, ambazo, and maybe in the theater you have several cases, and then you do not have time to wash this, disinfect it completely. So you can use it. You can use it on different patients, but you have to use a very good filter. Sawa sawa. So we have this one, and it's cost effective also. I have to mention that so that you do not think like those silver ions and then the price is like crazy. No, the prices are optimal. Sawa sawa. So these are the silver ions. If any bacteria comes into contact with the circuit, whether it's inside the circuit or outside, it gets deactivated by the silver ions. Sawa sawa. So its main aim is to reduce cross-infection and incidences of resistance, okay? So it has been tested against these bacteria, E. coli, Staphylococcus, Klebsiella, all these bacteria, and it's very effective in deactivating them. Sawa sawa. So you can use it up to 7 days, cost effective, environmentally friendly. Now I'll move to this other item here, this one. Obviously we are not able to give every hospital for free, yeah? But I can demonstrate to you how we are going to use it, and then maybe we can, tunaweza kuwaletea, okay? So this is the cuff manometer. It is meant to regulate the pressure of the cuff, of the ET tube cuff, sawa sawa? Because if the pressure is not adequate, then the aspirations are going to get into the patient's trachea, right? You end up with a VAP, right? If it's too much, then you end up causing compression trauma to the patient's trachea, sawa sawa? Which is not good for the patient, especially the ones that are critical. What you need to do is to have a very, the one that the pressure is optimal. It doesn't cause pressure and it doesn't allow aspirations. So this manometer, it helps in regulating that pressure. It has ranges that shows you that the pressure applied on the trachea is between 20 and 30 centimeter water. Sawa sawa. So what you do is you just connect it here with this valve, and then you inflate it. Okay? And then you inflate. So I think my cuff is not integral. Yes. You see? So sometimes in emergency, I know we are using needles, most of us. So you're using needle to inflate the cuff. So how do you, after sometimes you want to test your cuff integrity, how do you test it? You come with the needle again. What do you do? What do you do normally? How do you test it if it's still integral? You check the valve. Yeah? So this one, after some time you want to check the integrity, just come, insert it here. And you check if the pressure here is still in the green range. Sawa sawa? Okay? So that's how you ensure that the cuff is the pressure is optimal. Okay? Now you have finished with the cuff, you want to dispose it, right? Oh, actually I didn't mention something. So maybe you have inflated the cuff and then you have inflated up to the red range. Okay? You want to deflate it so that it's optimal. So you just use this valve here. Unaipress kidogo hivi, slowly, and then this one comes, the indicator comes to the green range. So this one is used to deflate it, and then this one you're using to inflate, okay? If you want to dispose it, you have to ensure that the cuff is 100% deflated, so you just use huku chini huku, ili isiende kubust. So you do that, and then you see. Okay? Sawa sawa. So this is the cuff manometer. We are encouraging it to maybe you can have several in your theater. Maybe for every theater you can have one. In the ICU, in the emergency, you need it because you want to reduce the risk of causing trauma to the patient. Sawa sawa. So this is the cuff manometer. Looks like that. You have to ensure that the cuff pressure is within the green range. If it's way above here, then you are causing trauma to the patient. This one is for maybe you want to test the you are using the LMA. So you can the LMA inaweza kuchezea huku. But for ETT you have to ensure it's around here. Sawa sawa. So you can use it very much in all the departments of the hospital. So why use the cuff manometer to reduce? I think these are. So these are the features, and then you have this one, the eye view. So why are we using the video laryngoscope? You want to ensure that your first intubation is successful, so, and you can do that by ensuring that you are seeing the pharynx very well. So this one, unaitumia tu is one size for all adults. Macintosh blade, okay? It's recommended for single user, and then you dispose it. So that's what the manufacturer says, unless maybe you will have your own ways of disinfecting it, and then you can use on different patients. But I am recommending for, Dr. Moise, I'm recommending this one for single user. Yes, so, but you can find your own ways of disinfecting and reusing on a patient, okay?
The concept that the global world should be thinking.
Yes.
If
they are thinking global, they should also think local. In terms of Tanzania, this is not feasible.
Okay. So me as a person who is in Tanzania, I would recommend that you find ways, because the battery can last up to, I think they say up to 25 hours life, 20, something like that. So you can, ukitumia, you just turn it on the go, and then you unaangalia, and then you shut it. Unaitumia and then you shut it. Okay? I think you can wash it, you can disinfect it and reuse it. But the manufacturer recommends single use. Okay? Sawa. So why would you consider something like this? Maybe you do not have the ability to have those big video laryngoscopes that are very this is not very expensive. It's cheap. It's not very expensive. It's around 600,000. Yes, 600,000. And then you have a video laryngoscope. The other one I'm quite sure is up to 2 million, right? The big one. And then maybe it's an emergency. Maybe you can keep only maybe one in maybe for emergencies. Unaitumia only for emergency cases. Okay? Sawa. So that is the eye view. So this is a study that showed that if you intubate more than one time, there is a high possibility that you are going to cause trauma to the patient. Okay? So if you intubate 2 or fewer times, they found that you are going to, there is a 10% possibility of the patient going through hypoxemia, a 1% chance of severe hypoxemia. All this if you intubate more than one time. That is why we are recommending this one, so that you are able to intubate with the first attempt. Sawa. So this is the eye view. Looks like that. These are the features. It has an LED screen, one size for all adult patients. Yes, basically that's it. Now, I also wanted to mention something about filters. I don't know whether all of us are using filters. Yes? Mwananyamala are using HME filters? Are we using HME filters? HME, the normal HME. Yes. We're using those ones. Now, how are we protecting the machines? Ama, where are you putting your filters? Huku kwenye mdomo au kwenye mashine? Kwenye mashine, pande wa nyuma. Mahali ambapo hewa inatokea kwenye mashine, hapo ndo unaweka filter, sio? Right? So what if the patient akipumua nje, the expired air inaingia kwenye, are we filtering that? No? So this is the breathing circuit, right? So I want you to understand where you are putting your filters. Unaiweka maybe in the ICU, unaiweka huko au unaiweka huko kwenye mashine, huko kwenye huko inakotokea huko. Where are you? So where are you putting it? Kwenye mashine. Huko ambapo hewa inaingilia. Dr. Moise.
So just to elaborate what he's saying. So he's marketing 2 filters.
Yes.
There is a HEPA filter, okay, and there is a HME bacterial viral filter.
Yes.
Okay? So this will be at the patient end, and that filter will be at the expiratory end. It's expiratory where the machine. So I know that HEPA filter, it just protects the machine not to get more harm with that the contaminants. Okay, so it just prevents long life of the machine, and also it protects those people around the patient. It's because this one will be connected on the expiratory port. Okay, so when the patient expires the air and goes into the machine, it gets filtered out and then the exhaust out. So we as a health personnel will be around the patient. When we are inhaling that air, we should not be getting that transmission. So that's the essence of HEPA filter, the yellow one. HME, on the other hand, has 2 functions. If for those people who are not using humidifiers, the machine where we heat and humidify, So you use HME, which uses the patient's temperature, okay? And it has a specific filter. It moisturizes and humidifies the air. Remember, the patient, when we intubate, we are bypassing the nose and the mouth. So the nose and the mouth, the purpose is we have all the ciliars and then the hair to humidify. When we tube, the oxygen is very cold, dry. So when you take that oxygen in with the ETT, you get a cold and dry. So HME does it to humidify. You'll see some water droplets. It prevents the secretion not to get clogged up. It does not get dried up. So that's the key purpose of HME. Humidified, membrane, exchanger, filter, and plus additional viral bacterial filter.
Perfect. Umeelewa hiyo? So this one you're using to moisturize the, kwa sababu when the patient is breathing out, anatoa na moisture from their lungs, right? So the moisture is trapped here, and then when they breathe in, hiyo moisture inarudishwa kwa mgonjwa, okay? At the same time, is filtering the air that is coming from the ventilator. Sawa sawa. So you are protecting the patient, at the same time they are returning their own moisture back into their lungs. Sawa sawa. Now this is what I was saying about this. So these ones most people are not using. So sometimes patient ametoa the aspirations zinaingia kwenye the secretions zinaingia kwenye machine. Or the moist inaingia kwenye machine, and then you end up having machine ambazo they do not last. So you need this one to protect yourself, as Dr. Ismail amesema. You protect yourself and also you protect your machines. Sawa sawa. Now, this is what I wanted to ask, because obviously there are these filters everywhere. Yes, yes, Dr.
How often do you use filter per patient per day?
This one. So this one is recommended for use for up 24 hours maximum. 24 hours you dispose it. After 24 hours you dispose it. And you do not, I saw some places they are washing it actually. Oh no, you cannot wash this one. Kwa sababu ukiosha the electrostatic filter on this, it's not going, it absorb mud, it's going to swell. Okay?
So if it swells,
yeah,
you'll get the airway pressure very high.
And
then you will be surprised that is the patient problem?
Yes.
Circuit problem? Kumbe is a filter.
It's the filter. So do not wash it. It's cheap, so I think you can dispose. Okay? It's not very expensive.
How cheap?
This is 7,500. Yes? It's reasonable.
Now tell me about
this. So this one is recommended for use up to on the machine end, okay? So you can use it, obviously maybe it's one patient kwenye ICU anakaa siku nyingi. You can use it up, it's recommended for use up to 72 hours. But based on your discretion as the clinician, ukiona kwamba it's not very soiled, it's not, the patient hana secretions nyingi ambazo zimeingia huku, then you can extend it up to 7 days. Sawa sawa. But that is, yes? You have a question?
I'm surprised.
This one, this is 45,000. Just 45,000, but you use it for up to a week. Okay? Yes, after 7 days you discard. You get another one. Yes? Dollars. So this is, it's called the AirGuard. The AirGuard breathing filter. This one is called the Cleartham filter. But actually this one's zuri sana easy, because you want to ensure that your patient is getting adequate moisture. You know, I have a case. I had a case in one of the biggest hospitals hapa Tanzania. So they had bought filters from somewhere, I don't know where. And then ukiekea kwenye mgonjwa, then inaanza kusikia alarms. You get the alarms. Why? Because the patient is not, anaanza kuwa dry. The knee is getting dry. They are having a very thick secretions, and they have a filter that is supposed to return the moisture. So what you want to ensure is you know how much moisture you are getting, your patient is getting from that filter. So this is what I was recommending. Kwenye nini ya kwangu jana.
Just to add on.
Yes.
This filters, I know this is an adult filter.
Yes.
There is a pediatric and there's a neonatal.
Yes.
How do you know? Based on the tidal volume which is written behind.
Yes.
So this provides at least 200 to 700 mils of tidal volume.
Yes.
Pediatrics is of course lesser, and neonate is a bit lesser than
yes.
that.
Yes.
They have a different HME. You don't keep adult HME in a neonate or nor in a
pediatric.
But it has to be said that this is not for all patients.
Yes, yes. Inakuwa imeandikwa because you have three types.
If your patient is not
yes.
completely paralyzed, would you use an HME filter or would you use the bed system?
Samani?
Humidifier. Would you use my humidifier or would I use this HME filter?
You can use that.
Okay.
You know why? Because it's called heated. You're using the patient's temperature.
Okay.
You're using the patient's temperature. So irrespective if the patient is paralyzed or not, if the patient is hypothermic, that's not useless.
So it depends on the patient's
temperature. So because then it's called heated. It's not. It's like HME because this does not produce heat.
It retains
moisture. That's all. Because
yes.
It relies on the body's temperature of the patient. That's 36, 38. More heat, more moisture. Now, if some patient is like that 34, 35, this is useless. And that's number two. If someone like especially COPD, that's also useless. They have a very sick mucus, will have so much of high alarms. So best is used the humidifier.
So basically, that we cannot use this in all patients.
Yes, not for all patients. So you have to choose between the for active humidification.
We're anticipating that this patient probably is going to be in the hospital for more than 20 days. Is this a sustainable option?
I would, because you have to use it. Maybe I would recommend.
We usually only use ours if the patients can get ventilated for 3 days or less.
For 3 days.
Yeah.
Okay.
Otherwise you use a humidified section.
After 3 days, you switch to humidified.
People that are only there for overnight in ventilation or 2 days, we might use just that.
Okay.
Otherwise, we change to humidified section. Or if they've come in with pneumonia, those where we know they probably benefit from humidified section.
Sawa. Is that clear to anyone? To everyone? Sawa. So this is what I was suggesting. So when somebody is bringing you these filters, I think you should just ask them, how much moisture am I getting from this one? How much moisture is my patient getting? So that ukienda kulala then because if you use the other one and then at night somebody is calling you, oh, your patient is clogging the ETT, imefungana nini. So with this one, I have the studies here ambazo zinaonyesha the exact moisture ambayo unapata from using this one. The other ones, the pediatric na nini, you have to ask them. Or you can just test yourself for anapata kiasi gani. Sawa. So these are the tests that I have here for anyone that would like to see the moisture that you're getting, the bacterial and viral filtration efficiency, so that you are sure. Sawa. Just so you are sure, usiwe unamwekea mgonjwa alafu unapigiwa simu usiku. Okay? Sawa. So that is our filter, the machine and the HME filters. We also have this one that Dr. Maynard may recommend you use it kama you have trained on it. Okay? It's very good for, it's a second generation LMA. It's modified, unlike the other one, so that it does not have you do not have to inflate this cuff. Okay? With the LMA, you have to inflate. You insert and then you inflate. Okay? So with the inflation, you have the risk of compression trauma. And then with the LMA, there is a very high possibility of mgonjwa akiturn that thing is because it's round. So this one, it comes with this buccal cavity stabilizer. That is the shape. If you look at it, the shape hii iweze kuzunguka ikiwa imewekwa kwenye mdomo. Okay? So it reduces that risk of rotation, and then insertion is very fast. Unlike the other one, you have to insert, to inflate, and then you check for the pressure if it's too much or whatever. So this one, you just insert. You can insert it up 10 seconds. 10 seconds, you're done. Okay? But we are going to do more training on this one, as Daktari amesema, so that you can just know how to use it. It's very nice compared. If you're using the conventional LMA, then I think this one would be a good replacement for that one. Okay? So it has a gel, a soft gel. It has an epiglottis rest. I don't think the other one has it. The LMA. So this one, it prevents the epiglottis from folding back, and then maybe utamuumiza mgonjwa ama hewa itakuwa haingii vizuri. Sawa sawa. It also comes with an integral bite block here. This material is quite hard, so mgonjwa akiuma. The other one is soft, so mgonjwa akiuma haiwezi ku block, okay? And then it has a gastric channel here. So maybe the patient is regurgitating, you can just insert the suction tube, and then you suction from kule kwenye esophagus, okay? You insert, and then unakuja una suction hizo secretions za mgonjwa or the gastric, hivyo vitu vinatoka tumboni, okay? Several sizes for, nilisikia kwa pediatric ndo zinatumika sana, right? So we have from the neonate size, this one, we insert 10 seconds kwa mtoto, and then unampatia kama ni resuscitation very fast. Sawa sawa. These are our airways, niliwaonyesha jana. One piece design, you do not have a separate bite block. Mgonjwa akiuma, it doesn't dislodge, and then they end up swallowing it. So this is one piece design, very soft material here, and a very soft material at the tip. The other ones zinakuwa ziko ngumu kidogo, So sometimes unaingiza, right? Unapata umemgaruza mgonjwa. So Dr. Fatma told me they have changed the protocol these days. You do not have to. And then you rotate. So you just insert these days. Hivyo tu. So at the same time, it's still risky if you're using a very hard material. So this is quite soft to reduce the risk of causing trauma on the patient's palate huku juu. Okay? Sawa sawa. And the price is the same as the other ones. So you just have that added advantage of maybe enhanced safety for your patient. Okay? These catheter mounts, we do have them. You can extend them. You dead space unaongeza, unapunguza based on, whatever you need. We have the bougies and stillets. If you need them, sizes, adult, pediatric, na neonate. Any questions? Any questions? Who's talking? Oh, any questions, guys? You do not want samples of this. Sawa sawa. Thank you so much for your time, guys. I'm sorry, najua tume. Thank you. Thank you. Daktari. Have a nice evening, everyone. Samples. So, let's talk. Right? Sample of video laryngoscope. So, before Dr. Moise comes to close the meeting, so this one, so I only have I think two or three ambazo I could give to all of you. Okay? I could, but then I can't. Okay? So, I think we are going to give one to the academy so that kama mtakuwa mnakuja for in the next trainings mtakuwa mnaipata, because we do not have many. Okay? So tutawapa academy, and then when you come back mtakuwa mnaipata hapa, and then we use all of us. Sio? But you don't like that. Okay? Yes?
That's the way.
Yes. So, but if you need niwalete kwenu, I can bring it. Of course, tumesema is just some few coins. I will bring it. We'll work on a very good price for you. You can have 2 or 3, alafu, politically speaking. Okay? Yes. You are supposed to, because even the other ones, people are not disposing the ones that don't have silver night still. Are we disposing? So this one, the good thing is for 7 days, you do not have to wash it up to 7 again and again. So you can reuse it without washing it. So I think after 7 days then. Yes. Yeah. Me, I would recommend you wash it and reuse it.
Ikiwa inatumika kwa mgonjwa 7 days lakini ukiambia assume patient atakaa hospitali. So
This one. You want to see it? Okay.
Yes. 3 days.
Yes.
Alafu akawa amemeka au whatever. Si umetumia siku 3. Naweza nikaitumia kwa another patient.
Yes.
Even if nimepita 3 weeks.
No. Ukifungua from the mfuko, you have 7 days of which that is
Whatever 7 days hata kama nikaa siku 2 zimemaliza, I have
yes. Because you know what, the study ambao walifanya, they only validated it for use to 7 days, only 7 days. That is when the time they trusted it.
So no matter ametumia siku moja, siku 7, siku ngapi, as long as once open after 7 days.
Yes. So that is what they tested. So kuendelea maybe mtu anaweza kufanya. So my number, would anyone like to take my number? Yes. Tutazungumza. Yes, this one is 600,000.
Nadhani nilipotea kwenye ile simu nyingine.
7 0 9 into 4. Yes, call me. So my number is 0767 0767. I have your numbers though. I'm going to text you anyway. 0767 019 124. Sawa. Jan's Healthcare. I'm intersurgical. Yes.
We're supposed to give us free samples so we can advocate for your.
Yeah,
I mean, how are we going to experiment? We have to give us free samples.
So.
We use it on a patient. We come back with the feedback and then.
I'm going to visit all the hospitals actually. Then nitawaletea. I'm going to visit. Of course, nitawaletea samples zingine because these are quite high end. Yes, done. Thank you. Done. Long press. How was it? Angalia basi. Yes, doctor.
Okay, good evening, everyone.
Good evening.
So it's very sad that today has ended. Yeah, only 2 days, but I'm sure we say when a child is born, he has like completely unused brain, okay? And I'm sure that up to what you have reached here, there was this small part of unused brain, which is now occupied with all the information which you have got in these 2 days, right? Yeah. Those who have never seen ventilators, now they are comfortable with the ventilator. Are you? If I'm getting you right, Salha, right? Now you know at least that there is something called as ventilator and how it looks like, right? And those who are already using ventilators, I'm sure that you've got a lot of things into it, right? So we did 2 days of some very interesting topics. And the first and for all, we started with why do we need ventilators, right? So we did the acute respiratory failure, and there you learned about the types of respiratory failure and what to do about it. Yeah. Then we went on to having the high flow and non-invasive ventilators like CPAP and stuff like that, and they showed you different type of mask which to be used when you're using the non-invasive type of ventilators. And then later we went into looking into the physics, the basic and the advanced airway. Yeah. And now I'm sure that whenever you have been called to go and see the patient who is unresponsive, what are you going to do the first thing? The patient is unresponsive and you have been called, come help. What are you going to do? You're going to assess what? Airway, that comes the first thing, right? Do you only assess and leave, or do you assess and intervene? What are you going to intervene? How are you going to intervene? Would you require all those fancy equipments which are there? Yes? When intervening for the first time, the basic airway says what? Open the airway with only your two hands and an assistant and an ambu bag. That's enough for the first foremost intervention which you need. Are we together? Okay. Then we went and said that yes, laryngoscope is a very good equipment and it's a very useful equipment, but it is also a murder equipment. So you need to be very careful with it. You need to know when to use it. You need to know how to use it. You need to know your blades. You need to know the aftercare of once you have intubated the patient. And you need to know whom to intubate and whom not to intubate, okay? Later on we went and talked about, Reena talked about can't intubate, can't ventilate protocol. The whole protocol was kept, and there was a very nice checklist which she shared with us about the airway. When you want to go and intervene about the airway, what you need to do from the patient to the equipments to the people to the now the procedure. Remember all the preparation for the airway? Do you remember the checklist? And luckily enough, we have given you the checklist. So please just don't go and close in your... Can you all show me the checklist for the airway? Because I need to know whether you really were listening yesterday or we were just bluffing here. Can I see the airway, please? Checklist for the airway. So somebody is peeping on the neighbors. Are we all together? Yes, that's the one. Yeah. So you remember this checklist? Yeah? Okay, so make sure that you don't just leave it in your file. What I would encourage, whatever you have grasped in these 2 days, especially those which are implementable, like this just needs for the director to know you need a copy and you need to paste it and you need to circulate among the people who are dealing with the airway, from the emergency department to the theater to the ICU. Okay, so go and have a talk on this with your colleagues who were not able to attend today. And then train them and then use it. This is not just been to be kept in your folders, this is to be used. I know that I'm going to implement in my center. So I made my checklist up to here, and so I'm going to increase this part of it. And there's some bits and passes which I haven't included. I'm going to modify my checklist from this one. Okay? Sawas jamani?
So you print, laminate, crush to,
or just leave it. You can even like keep it like the longer one. Like for example, we have the very big ones in our recovery areas, because recovery area in the theater are usually forgotten places. They are like abundant places that nothing can go wrong there. So we made sure that we have printed a bigger one, like A3 ones, and kept them there. So if anything happens, and remember those are the nurses who are like PACU nurses, not trained. So you need to have more bigger one and try to have training as much as possible. Okay? Then we came to me, who I talked about what? I talked about what? Basic, yeah, physics. One part was physics, then, like seriously? Yeah, no, I didn't talk about the mods. She talked about the mods. Okay, I also talked about the complication when one can get through the ventilation. And lastly but not least, the other part of the ventilator. So we talked about the physics, the bits and pieces of the ventilator, and the complications one can get if you put the patient on the vent. And the only thing I told you to go home with was that formula. Make sure that formula you remember. It was repeated again in today's class. So make sure that formula will help you to set or alter the modes in your ventilators, okay? Not only the modes, but also the settings in the ventilator. That formula, it's very important. So once you get like high minute volume, or it says high peak airway pressure, that is the place where you can alter and see what is going on with the patient, okay? Later on, we talked about now the basic modes of ventilation and the settings, and then we did a practical of 4 stations, and then we rounded up. Who can remember the stations of yesterday? One station was about? Shamim? Mechanical ventilation. 2? Non-invasive ventilation. Anybody else? Practical, Yamani. Airway, yes. So they told you about all the equipments which are needed for the airway, the basic airway. Yeah, anything else? With Rama, what did you do? Okay. And then anything else? In the middle? Those ones, the promotion stuffs, right? So but you learned about them, and you know that, see, the first thing which we do mistake, we think that the hospital is supposed to know everything about the procurement. Then you lalamika, you say, oh, I did not get the right equipment. When somebody tells you, please give me your order, just don't say, I need ETT. Be specific of which type of ETT do you want, which numbers do you want. Is it an adult or a pediatric? Is it a cuffed or an uncuffed? These are the things you're supposed to. And Rama did a very good thing of keeping this station, because this stations gives you now an idea of knowing the specifications of the equipment you need to use. You can't just say, I need a laryngoscope. You have to be specific of which type of laryngoscope. Is it a video or not a video? Do you need a straight plate, or do you need, like for example, in my setting, the anesthetic provider, they said they only bring Mark 3 up to Mark 3. They never make Mark 4. I'm like, do you write it down when you say that I want laryngoscope with 4 Mark? Mark 1, Mark 2, Mark 3, Mark 4. Is it a straight blade or is it a curved blade? Do you specify that? If you don't specify that, then how do you think the things will come correctly? So that station was very, very important, I believe. Then we called it a day. And I don't know what you did after coming out from here. Did you go to your own house or Nyumbandogo? None of my business. And then later on, we came today, and we started a bit late because of the CME. But we did with Dr. Asha, the post-intubation and the routine care of the ventilated patient. I also forgot that you did a topic with Asha yesterday about the... Yes, exactly. So later on, we did about the house care keeping in critical care with Dr. Ismail. Then we did the MV troubleshooting with Dr. Maynard. I think I got the REM correct, right? Maynard. And he talked about the physics again, but he also went through the troubleshooting through the same formula. So what you know that when you have in the high inspiratory pressure, what do you need to do? When you see there is a high minute volume, what do you need to do? So always remember to balance the volume and the pressure. Then later on, we talked about communication. So who can tell me what IS bar stands for? IS bar stands for I introduction, excellent. S situation. B okay, excellent. So how many of you are going to recommend this course to your fellow colleagues? Hands up, hands up. Okay, so you backbenchers, you don't want to. recommend us? Are you? Zalha? You're not going to recommend us to your fellow colleagues? Are you? No? Seriously? I'm sure she means yes. So unaenda kutupendekeza au sio? Umefurahi hizo siku mbili au sio? Kwa nawaambia kwamba waje tena au sio? Kwa next time when you come you bring 2 colleagues with you. Okay? Excellent. So that is what we did. But also when taking care of the housekeeping situation in ICU, what did we talk about? The monitoring. How do you monitor what are the mnemonics which you need to use when monitoring your patients? First hug. So you hug your patient twice in a day. Always remember that, okay? Hug your patient twice in a day. That is what BID stands for. So who can tell me what is F for? All together. Then thromboembolic. H. Head up. U. Also prophylaxis. I. Indwelling catheter means all the catheters. Okay, whichever catheters, even ETT is an indwelling catheter. Urinary catheter, CVC. Only? All invasive, yes. What else? D is? So in discoloration is not only about the medication. Remember, the moment you put your patient on the vent, you plan to remove the patient from the vent. You remember, always remember this principle. The moment you put your patient on the vent, you plan to remove your patient from the vent. So in deceleration goes also about your setting. Don't be happy if you're keeping your patient on SC mode all the time. Try to also change the mode and see how your patient is doing. Okay. Then later on we went for tea, I guess, right? Yeah.
Even if you get EMD, those working in the emergency department, you also have the fast hack.
Yes.
Not only in ICU, because some of our AEDs, actually patients stay there more than 12 hours.
Yes.
So after everything has been done, everything's done, and the patient is moved to a recovery area, something like that, you also start fast hacking the patient in many other things that can be done.
So I will just share a small story about our EMD. Our EMD was opened in 2019, and it was the very first time to have EMD in our center. And at the same time, ICU was opened and dialysis was opened. So 3 areas were open in our hospital. So usually patients stay in EMD for 1 hour or 2 and they are disposed. But when an emergency physician came and he kept on keeping the patient for 24 hours to 48 hours, everybody started complaining, oh, the patient are staying so much in EMD and they are not moving. So the emergency physician said, unless my patient is stable, is that when I'll dispose the patient. So what Rama is saying is true. You do first hug BID your patient in EMD, okay? Obviously the deceleration part will come in ICU or wherever they have been disposed, but the other parts you need to take care of the patient there, okay? And then later on we went into the topics about the breakout session where we did what? What did we do in breakout station today? The practical. We did a central line, excellent. ABG, wasn't it interesting? So I know now you're the pro in reading the ABGs, right? So remember, ABGs when you're taught today, if you don't go and practice, you are lucky that some of you, 4 of you are coming from the same center, right? So make sure in the morning when you meet, give them one of the ABGs which was done and then discuss. If you don't do that, believe me, whatever Dr. Ismail has taught will just fly over your head and land somewhere else where you will not be able to reach. So go practice and practice and practice. Go to your YouTube. I'm sure all of you have a smartphone. Go to the YouTube, just challenge yourself, come up with an ABG, interpret, and then see
how you are doing. I'm sure, Dr. Ismail, you'll not mind if they send you the answer of interpretation. Yeah. So send it to him, and then he'll say, this is where you were right and this is where you were wrong. Okay? Are we together, Jamani? Sawa? Excellent. And what else did you do? Troubleshooting. Excellent. So once we were done with this, and I'm sure that now you know at least how to troubleshoot. And one thing I would also like to tell you, please don't ignore looking at your ventilator, even if you know that the nurse at night was the excellent nurse. I always have a tendency, whenever I go to see my ventilated patient, I go and check the history. Because no matter what, remember, we work in a very constrained environment. And also working in an ICU, it's very challenging, it's mentally disturbing also. The alarms ringing of the vent, the alarms ringing of the monitors. There is a patient who has changed. There is a patient to feed. There are relatives who are so anxious. There is a doctor who is giving you orders. So it's very tense environment to work in. And that's why I tell you, it doesn't matter if you spend an hour on a patient, as long as you're giving a good care to your patient. So always go back in the morning and check your ventilators, how many times alarms have read. In a paper, it was seen that per patient in 24 hours, the alarm goes more than 1,000 times. It can go more than 1,000 times in 24 hours only. So remember that there might be false alarms, but there might be a very critical alarm which will guide you to give the attendance to the patient in the following day. So always go back to your vent and check if there are any alarms which were shut off without being attained. And the nurses, please nurses, don't be scared of the alarms. You are not alone in this boat. So call your fellow doctor, whoever is on the call, that there is this alarm which is ringing. And nowadays, I don't know how this vent, we have a smart vent. So the alarm goes in yellow, then it comes like it goes in a green, then yellow, then red, orange, then deeper red, and then deeper red, and then it's like all red. So it tells you that I've cried so many times, you're not listening to me. Okay, so please look for those alarms and try to sort it out with your nurses and the staff. Lastly but not least, we thank you all for taking out your time, for coming to be taught in this class. I hope that you have grabbed enough concept to go and change your practice. We'll be having some more interesting courses. Please look out for our website. We have a website, right, Rama? Yes. We have a website, isn't it? Do we have a website where they can go and check for the all courses which are coming up? Not yet, but we do have.
We do have a group for them.
Okay.
And we most of the time share all our courses in the group that you are in. So mostly Airway will be getting a lot of.
And then lastly but not least, Tanga is a very nice place. It has beach, it has mountains, it has beautiful people like us, Wasamba and Digo. So you're all welcome in Tanga. The only thing you need to take precaution, waja leo, kuondoka ni majaliwa. So unawahi kusikia kuogeshwa mna? Sitaki kuenda mbele. Asanteni sana.
We improve by listening. We understand we can't do everything positive. There are some things that we need to do to make it better. So please write. Kwa sababu umeattend this course, Emergency Medical Services Academy kushirikiana na Physician Association of Physicians in Tanzania tuna organize course ya basic life support. American Heart Association basic life support. Now the good news about it is it's going to be only 100,000. Kwa tunafundisha shilingi 250. Kwa kushirikiana na physicians tunafanya kwa shilingi 100,000 tu kila mtu. So you have an opportunity kufanya hiyo na kuungana na sisi. Na colleagues wetu Yansi naweza ukaja kutusaidia pia kushirikiana na hawa kuweza kufanya this Airway kwa sababu pia ni sehemu ya basic life support pia. Kwa hiyo And thirdly, tuna a much more extensive course basic assessment and support in intensive care. Kile kitabu kiko wapi? Kiko wapi? There was a book here. There was a book. This one. Kazima simu. Alikuwa okay. Basi tutaendelea. Kwa hiyo basic assessment and support intensive care, na zake content zake zile pale unaziona ziko huko ndani, na hizi zina kuprepare kuwa a more based katika ICU care. Inakufundisha kila kitu kuhusiana na how you starting going to become an ICU practitioner. You may not be an expert, but at least a person who can actually work in ICU, communicate nicely with the ICU experts, with the things that they are interested, assess your patient in a way that a critically ill patient has to be assessed. And this book actually go home with it. Usually this course tunacharge shilingi 500. Tunacharge shilingi 500. Ni course ya siku 3. Na kunakuwa na expert, iko ya nurses na ipo ya madaktari. Kuna special for nurses and special for doctors. The next course we're going to do it in Mwanza, itakuwa Bugando. Course inayofuata nayo itakuwa ni Mei. Alafu June tutafanya the same course, itafanyika Tanga kwa Dr. Naima. Tutaenda kufanya kule. Baada ya hapo mwezi wa 7 tutafanya tena Dar es Salaam Safi. Mwezi wa 9 kutakuwa kuna very good symposium itahusiana mambo ya stroke care. Tutaifanya hapa Dar es Salaam, tutawatangazia. Mwezi wa 10 tutafanya symposium ambayo tunaisha Semke, ambayo yenyewe inafanya multiple workshops mbalimbali. Ikiwepo ya basic, ikiwepo workshop ya Airway Management itakuwepo. Kunakuwa na parallel session. Kama hivi tulivyokuwa tuko hapa, kungekuwa kuna session nyingine inafanyika chumba kingine. Kungekuwa kuna session nyingine inafanyika chumba kingine. Kwa hiyo tunakuwa watu kama almost 200 au 300 tunafanya hizo session. Tumefanya hivyo mwaka jana CBD pale tumefanya Zanzibar, mwaka huu tunaenda kufanyia Mbeya. Itakuwa ni Oktoba kwa wale ambao wanatokea Mbeya. Other than that, mimi nasema nawashukuru sana kwa kuja na kuwa sehemu ya hii fantastic class. Na sasa kutokana na uwepo wa Rina ambaye yeye kasafiri kutoka all the way from Australia to come here. Dr. Ismail, yeye kaacha wagonjwa wake. He is very much in love with his patients from Indumandare. He decided to be here with us. Dr. Asha, yeye mnajua Moi is always busy. And she decided she's on vacation this time, but she decided to take part of her vacation to be with us, and we gratefully appreciate for the time that she spent. Dr. Naima, yeye kimsingi hapa Dar es Salaam ni kwake, na she has been nursing mother ambaye kidogo hayuko vizuri sana, lakini part of that kuja kukaa na mama leo kaamua aje kushare his vast knowledge with you. So we greatly appreciate for your time mama. Na huyu ni bosi wangu. Jamani, naomba nirudie tena. Bosi usinirudishe tena Tanga. Huyu ni bosi wangu. Dr. Maynard, yeye katoka KSMC. Of course kaingia leo asubuhi. Kaacha wagonjwa wake kule na ventilator zake na alarm. Kaamua aje. Najua kule nesi anazima tu ile alarm afu akilala kinachoenda. So thank you, Maynard, for joining us today, and your session have been greatly influenced every one of us, and probably will make a difference. And most of the time is the alarms, and this is the message comes from me. I know we like just putting off the alarms. The alarms are not managed by putting them off. You deal with what it tells you, and then you can put it off. You don't start by putting it off. You correct and then put it off. Other than that, sasa niwakaribishe Dr. Ismail on behalf of Dr. Moise, and Dr. Rina on behalf of EMSA. Please come forward. Yes? Itakuwa tarehe 21. Mei 21. Mtaona matangazo yatakuja, yani mtakuja na matangazo mengi tutapata. And So first of all, we will start with our faculty. Yeah, it's okay. It's okay. You'll be last. We will start with our faculty. The people who have made all this possible today. And I would like to call Dada Asha.
I'm giving a note.
The one here. Ismail, this side.
Okay.
Okay.
Okay, put it off. Okay, and then Moise is not here. Maybe someone will take for him. I'll keep it there, here. And then Sister Margaret. So Sister Margaret, she was there. Sister Margaret, actually, she was working last night at JKCI. She decided to come here because we called to share her vast knowledge on patient care in ICU. And she joined here with her uniform. So we thank you so much, Sister Margaret. And this is what we can appreciate your time spent with us here. Okay. Next is Dr. Naima. And next is Dr. Maynard. And then we would like to appreciate Jansti. They were here. They supported us. Anyone coming from Shifaa here? And the other person or other organization that has helped us is this venue. You can see in this decorate venue that we've been here, Shifaa has helped us to be here, and we thank them a lot. And then it comes to you. Joram? Jonas? Next? Safia, prepare. Rawia, George, prepare. Fatma, prepare. Weka. Vyeti vyake. Are you prepared? Matthew, prepare. Lamek, prepare. Dr. Harris. Anastasia. Selena. Peter. Jacqueline, prepare. Jacqueline, prepare. Shamim. Jacqueline. Jacqueline. Yeah. Weka. Weka. Angalia vijabaki huko vingine. Wangapi wamekosa? Watatu. Mmejaza hizo form? Angalia watatu. Okay. It's okay. We can. So now, next are going to be.
Sweets, everybody, just help yourself.
Dr. Asha, Dr. Naima, please be the witness here. I'm going to be the receiving person. You are going to receive.
Oh.
So this is for Rina. Rina is having also this one.
Wow.
Okay.
One by one, is it? Start with this.
Thank you. Ismail. Ana Ismail ana picha nyingi. Okay, that's fine. Okay. Haya, jamani, kwa wale ambao hamjapata vyeti vyenu, nafikiri kutakuwa either labda tulichelewa kujaza hizi fomu, lakini kama vyeti hakuna shida, vyeti wote tutapata. Nafikiri tu kwamba kwenye fomu hii, na nisamee mimi kwa sababu sikuwakumbusha kwamba jamani, hakikisheni kwamba kila mtu, lakini kila mmoja wenu atapata vyeti, atapata cheti chake. Na most importantly, kwa wale ambao madaktari wanategemea CPD, basi CPD zenu mnafanya nini? Mtazipata. tutawapeni CPD za kozi nyingine hizi bado, lakini kama ni za mwaka huu mmeshakamilisha, kuwapa za mwaka 2025 zitakapokuwa wamekamilisha tunaongeza kwenye darasa. Kwa nurses mnapata 2 CPD point kwenye hii. Kwa hiyo tuleteeni vile vitabu vyenu. Mna vitabu vyenu? Mnaweza mkaleta vitabu vyenu kwa mimi au hata mkaleta kwa mtu yote kati ya hao, wanaweza kukusainia tu, unapata 2 points kwa sababu ni accredited at TDMC, lakini tu kwenye process. Ukishakuwa accredited maana yake unapata almost 5 points kwenye activity kama ya leo. Sawa? Other than that, nafikiri nataka mpate picha, si ndio? Aha. Jamani, wakufunzi naombeni kama tutakuwa hapa mbele na wanafunzi wetu tupate picha. Tupate picha ya pamoja. Tuchukue hizo viti tuweke. Tuchukue viti